So DKA, what is it? Why does it happen? What is going on with DKA? It happens because of hyperglycemia that got out of control, right? And so have increasing cortisol, stress, immune response. Something's causing all this hyperglycemia. And to cause the hyperglycemia, we broke down glycogen, we broke down proteins, but really what's going on is the breakdown of lipids. So this lipid breakdown is what's causing the production of ketones, right? When lipids get broken down, ketones get made, right? And how do you not make ketones? How do you stop lipolysis? That's what insulin is for. Insulin is the off switch for lipolysis. So if you have insulin, which a type 2 diabetic does, they are lower risk for DKA. But remember we mentioned type 2 diabetics, they can exhaust their beta cells. They can lose all their beta cells, and now they are pretty much like a type 1 diabetic now, right? So DKA can happen in type 2s. It's possible, it's rare, it's uncommon, but it's definitely very, very common in our type 1 diabetics. Why is it common in type 1 diabetics? Because type 1 diabetics don't have insulin. No insulin, you get lipid breakdown. Lipid breakdown is ketosis or ketone generation, right? And there are 3 ketones, right? And 2 of them are acids and 1 is a fruit, right? So it makes you have fruity breath. Cool, right? But the 2 acids are going to start causing problems. They're going to cause acidosis. They're going to cause my anion gap to go up, for instance. Okay, so these are also negatively charged, and we talked about the strong ion difference of ions in the body, and all those negative ions, just like with chloride, with normal saline administration, it's going to start pushing other negative ions into the cells so that we can accommodate all these negative ions. And that will push bicarb in the cell and worsening our acidosis. Okay, so it's an absolute insulin deficiency that's causing this. So why does this happen? Well, it can be a new onset diabetic, a new onset type 1 diabetic. Would it really be a new onset type 2 diabetic? They'd really have to be working really hard and not have any complications over the last 10, 15 years, right? But type 1 diabetics, they have an antibody attack of their pancreas, or they have a genetic reason that they've stopped making insulin. All right, so they are going to present with these DKA symptoms. What are other reasons? Because type 1 diabetics just don't get DKA and they're done, right? Usually they're always bouncing back, right? In the hospital, out of the hospital. And the most common reason is the eyes, or eye for infection. They have a new pneumonia, a UTI, a skin and soft tissue infection, an abscess of some sort, like Fournier's gangrene. They have pancreatitis. They have some kind of inflammatory, infectious response that's making their body what? It's going to make their body release the SNS, release cortisol, and that's going to increase our blood sugar, right? And is there any insulin to turn off the lipid breakdown? No. So therefore you get this ketone generation, right? You get a lot of ketone bodies and you get this acidosis, or this ketoacidosis. What else would make us release cortisol? Cortisol is released when? With an SNS response, and what else? Any kind of stressor. Has been hospitalized, ICU stressor? Yes. So any kind of stress to the body would cause the insulin requirements to go up. And since you're our type 1 diabetic, you can't increase insulin. So therefore, you have an incredible stress of some sort. You have an infant because you are pregnant. You have a ischemia, right? Someone got some steroids. Yes, I could do it too. But they got ischemia, like myocardial ischemia. It could be a common reason for someone to present with DKA. So when someone comes with DKA, you're going to see the provider order troponin. It's like, why are you ordering troponin? Right, what does that have to do with hyperglycemia? There's really no connection there, right? But it's an incredible stress to the body, and that's going to cause you to require more hyperglycemic coverage, right? Which is what insulin should do. You can't release insulin because you're type 1 diabetic. Therefore, you get lipolysis and ketosis, right? And then commonly, insulin costs money, right? So how much does it cost? To get last calculation was like 18 to 20 cents per unit, right? Which is a lot, right? If you're giving 50 units per day, that's like almost $10, and like that's $10 a day. That's more than a Starbucks coffee per day. And a lot of people, when I was in college, I couldn't afford $10 a day. That was literally impossible, right? So they have to choose. Are they going to get gasoline, or are they going to get food, or are they going to use insulin, right? So being insulin deficient because they are non-compliant. Non-compliant comes with connotation that they refuse to get insulin, they refuse to manage their health, but really it could just be finances. It could be that they can't afford the insulin. Okay, and drug activity, that can be, they're choosing between drugs they want to intake and not intake, right? So drugs can cause you become insulin non-compliant, and lifestyle diet. They're not changing their lifestyle, which can put them at risk for need for more insulin, and therefore put them at risk for DKA. Okay, and we mentioned a new type 1 diabetic is also a common reason for someone to come to the hospital with DKA. So what are your symptoms? So nicely, it is DKA. So you got D for diabetes, K for ketones, another K for potassium, and we're not going to say another K here. We're going to just keep it at 2 Ks. But then we have acidosis, right? Acidosis is your pH is less than 7.30. I thought acidosis is less than 7.35. It is. It's just how they define it. Okay, so less than 7.30. They're going to have a HAGMA. What's a HAGMA? That's a high anion gap metabolic acidosis. So the anion gap was just your sodium minus your bicarb minus your chloride. And then if there was something added to that equation, that would make, and that something is usually acids, that's going to make my anion gap higher, right? Because my bicarb is going to start going down because I'm starting to buffering it. So it's 140 minus not 25, but 5 because I'm buffering so many acids. Chloride is going to be normal. And then I have all these unmeasured ions. Unmeasured, what ion? The hydrogen ion. So I have this anion gap that is incredibly high. So I have 30 unmeasured ions, and I can deduce that they're type 1 diabetic, they're not taking their insulin, they have a MI. It's probably the ketones that are causing this acidemia. Because I know that 2 out of 3 of these, acetoacetate and beta hydroxybutyric acid, those two are acids, right? They're going to release hydrogen ions in a solution, and they're going to cause me to become acidotic. I can measure those ketones. How do I measure them? Well, 2 ways. I can measure on the urine. I can measure urine ketones, right? So where are we at here? So ketones up there. All right, so yeah, so you can have urine ketones or serum ketones. Urine ketones, when they do like a UA for ketones, they're measuring acetoacetate. But what's the most common, what's prevalent ketone? That is BHB, or beta hydroxybutyric acid. All right, so BHB being positive, right? And it's only found in the serum, actually. That's the one that they're going to be running. All right, they could have had ketones on the UA and the ER, but they're going to do a follow-up serum ketones. Okay. Yeah, I mean, yes, DKA is be the most common. Like that's be like your number one thing you're thinking of. If someone's ketones are positive, like, oh, they got DKA, and they don't have type 1 diabetes, they don't have like infection, they don't have any distant history of diabetes, none of their relatives through the last 200 years had diabetes. Well, then you realize that maybe they're just starving, right? Because they have ETOH use or they have starvation ketosis. Those are the other 3 key reasons to make your ketones go up, right? Or you're on a ketone diet, right? That could be it as well. Okay, and those guys are going to have the same presentation. They're going to have these ketone elevation. They're going to be acidotic. When someone that has alcohol intake constantly and they're starving, basically, then your body's going to go through lipolysis, right? So, and this is the idea with a ketoacidosis. You have ketones that are present. We know that 2 out of 3 are acids, so we get acidosis as well, and a HAGMA. Okay, and that's acidosis causes like non-specific symptoms. It causes them to have abdominal pain. There's no clear reason why it causes abdominal pain, but they get this abdominal pain, they get nausea and vomiting, right? That enteric nervous system, that's, you have your SNS, your ANS, your PNS, your CNS, you have all these NSs, and there's another NS out there, that's your enteric nervous system. It's recently discovered the last 10 years or so. You have your own enteric nervous system that's doing its own thing, completely separate to all the other sympathetic, all the other nervous systems. So it's doing its own thing over there, and now it's irritated. So that's why you get nausea and vomiting as well. That's also why when you take a foreign medication for the first time, you get nausea and vomiting, because your ENS is all like, what the heck is this? And it starts freaking out, starts getting tachypupia, starts making you get get diarrhea and vomiting. All right, then back to, so K for ketones, K for potassium. We know when acids go up, right, it's a positive ion, and it's going to change place with another positive ion, right? Because your body's like, oh shoot, it's acidosis. I can't deal with acidosis. I'm going to put that acid into the cells in exchange with potassium. So your K will go up. So hyperkalemia is also found, but these patients have diabetes symptoms, or the 3 Ps, right? And the three P's are polyuria and glucosuria. And when you pee a lot, you also have a low potassium. But they are acidotic, so it looks like a falsely high potassium. So their potassium body-wide is actually very, very, very low. So these guys need potassium. As soon as their K gets less than 5, then it's time to give them potassium. Okay, I thought I put it on here, but yeah, so the potassium starts to get less than 5, so K less than 5, right? Automatically we start replacing potassium because we know that once they start getting corrected, they're going to, the hydro ions are going to go away, the potassium is going to come out of the cells, and there's not going to be enough potassium around. All right, so how do we know that they're getting better? We look at the chemistry. So the chemistry is a key piece to tell if they are, yes, the glucose is getting better, but really the glucose is not what we're worried about. We're worried about the ketosis, the ketones, and the acidosis. That's what causes death. The hyperglycemia is not going to cause the problems. And we mentioned with certain medications that you can have a euglycemic DKA, right? So euglycemic DKAs can happen with your SGLT2 inhibitors, right? Those guys prevent the glucose absorption, and their sugar is like 150, and they have ketones, and they have acidosis, abdominal pain, nausea, vomiting. They got the three P's happening. So that could have you can have euglycemic DKA. So really the key piece is what is the anion gap. That tells me that ketones are gone. I'm not going to have a rise in acids anymore. Therefore, my anion gap will start going from 30 down to normal, which is 12-ish, right? So chemistry, Q4 hours to make sure that we're closing the gap. The gap is getting lower. And sometimes you'll look at the sodium and you're like, oh shoot, the sodium's super, super low. What are we gonna do about that, doctor? And they're gonna look at you silly because we don't care, right? Because why do we care? Because it's the glucose, right, is gonna pull a whole bunch of water into the serum and dilute the sodium falsely. Okay, so we want to make sure that we are, correcting the sodium. So the corrected sodium is about 2-ish points for every 100 points above 100 on the sugar. So if it's a sugar of 500, right? So 2 points, right, for every 100 beyond the 100. That's 4 100s beyond 100 is 500, right? So it's 4 times 2, that's 8. So if my sodium is 138, my actual sodium is, did I say sugar? If my sodium is 128 and my sugar is 500, my actual sodium is 136, which is not a problem. Okay. So ABGs, usually we do initial ABG. You don't have to do like serial ABGs, but the initial ABG or the pH is like super, super low. We have to do some more like some bicarb therapy, not bicarb push, but like isotonic bicarb infusion. And then the other danger, and we've had patients arrest because of this, because usually they have this extreme abdominal pain, and they want, they're like, I need morphine, I need Dilaudid, but they are breathing super fast because they're super acidotic. Their pH is 6.89 with DKA. Giving Dilaudid or morphine is going to make that 6.89 go which direction? Make it go down, right? So they're going to get a respiratory acidosis on top of it, which is not ideal. Okay. And then we got to look for the infection because we know that they have an infection. We can do like some tropes as well, right? So we're going to see if they overdosed on like aspirin, because aspirin is an acid as well. That's a stressor to the body. We're going to do a HCG to make sure they're not pregnant, because we know that can also trigger someone's DKA. So those are things we're looking for to see, infection is the most common. So we're going to do a whole survey, cultures, blood cultures, lactate, all those things, right? And if they have lactate elevation, that's also going to be added to the ketone elevation. Okay, so that's the idea with a DKA patient. Right, they're extremely acidotic, they're hyperkalemic falsely, and they're hyponatremic falsely, and they have these symptoms of a diabetic, and they also have symptoms of the acidosis. So how do you fix it? So the acronym is FI, or Fee-Fi-Fo-Fum. So FIE is fluids, insulin, and electrolytes. So we just talked about the electrolyte story, right? The electrolytes, you could get hyperkalemic, especially if you develop a chronic kidney disease or an AKI on top of this infection, or on top of this MI or something. That's going to really make your K start going higher and higher to the point where you can get a sine wave and you can sign out to asystole. But once the K starts getting less than 5, though, we have to consider that we know that they are whole body potassium low. So they need to get their K corrected once K is less than 5.0, right? So over here, so 3.5 to 5.0, We're checking Q4 hours. We're making sure that the K is greater than 5.0. So greater than 5.0. All right, and then going back to fluids. So what's the priority between these? It's like they're all the same. You're going to have fluids and insulin, right? And then keep measuring the electrolytes to make sure the electrolytes are corrected. And we do that with the Q4-hour checks. But fluids, they get a large volume of fluids, right? So up to 50 mLs per kilo, right, is how much they're getting. And they're getting, up to 50 mLs per kilo in the first 4 hours. It's usually 10 mLs per kilo per hour. So if they weigh 60 kilos, for instance, that's 600 mLs an hour for the first 4 hours, right? So we're going to get a lot of fluids going into them to get them hydrated because they're extremely dehydrated, right? There's a patient that it's okay to give a lot of fluids because they came in extremely dehydrated. All that glucosuria pulled all the water and made them extremely dehydrated, right? And then we have which one's the better fluid? And we know the normal saline causes acidosis in AKI, so LR is usually their better fluid to choose. And then insulin, we're not giving sub-Q. There are strategies out there where they do give sub-Q insulin for DKA, but those are like moderate DKAs where they're not extremely acidotic. They're actually okay. Gap is like 22, and we're going to do like some of this fancy sub-Q therapy protocol. And they can even go to like a PCU in that situation. But if they're super sick, then they're definitely going to be getting IV insulin, and that's only regular insulin, right? And then when the DKA is resolved, we're going to switch them over to sub-Q long-acting. That's where they kind of overlap. You don't turn off the IV insulin immediately because that's going to go away in 20, 30 minutes. That's how long regular insulin takes, right? You have to start a long-acting insulin, and then about 1 to 2 hours later, then you turn off the drip. Okay. If you bring the sugar down more than 50 to 100 points, all right, so you're bringing down the sugar nicely, 75 points, 80 points, 60 points, then you bring it down 200 points. Well, the brain can't catch up. So the sugar on the outside in the vasculature drops so fast that it becomes hypotonic. And all that water is going to rush in and cause cerebral edema. So we have to make sure the sugar is coming down nice and slow. Okay, and that's the whole point of doing Q1 hour checks. All right, don't get overcorrection to cause hypoglycemia. You bring it down about 50 to 100 points per hour. All right, so once you get under 200, we are going to make sure we're adding dextrose because that's going to stave off ketosis, which is good. We'd want to also get ketosis as well on top of everything else. And then hyperkalemia, as we mentioned. If they have an AKI on top of this, that's going to put them at high risk for hyperkalemia. But we expect them to have a K of like 5.5, 5.7. But once they start getting K at 4.7, they can dramatically drop their K very, very quickly, and that's why we always preemptively try to give them potassium once the K drops below 5.0, right? So less than 5.0 equals treatment. So the advisor, so we talked about this over in IV titrations, kind of the same thing. We have the initial phase, all right, where the ED does, where we're resuscitating them, and then we have the subsequent phase, which is what we receive the patient for, right? So we're going to be giving fluids still. We're still maintaining fluids. And we want to be checking this little box on the subsequent phase. And that is the key thing. So the computer knows what fluids you're giving. Because sometimes you need to add sodium. Sometimes you need to not give sodium. Sometimes you need to give glucose. Sometimes you not need to give glucose. So we want to know what to give, right? And the only way the computer knows is based on the rate. It looks at the rate there and it checks to see which rate matches, right? It's like, does this one match or that one match, right? This one is D5 water at 250. This is D5NS at 250. This is NS at 25. And this is NS at 125. So what do you want the computer to do? How is it going to know what to do, right? So it's our job to clean up this MAR to make sure it makes sense, and also make sure this box is checked so that the it knows, hey, I see that you're running DLR and your sugar's under 200. Let's add dextrose to that. Let's add it to D5LR, for instance, right? Or it says, hey, your sodium, your corrected sodium is 131. Let's add normal saline to this, right? Instead of D5 half NS, right? So if your corrected sodium is like 142, right? Like your actual sodium might be, or sorry, your pseudo sodium might be 134. It's like, oh, it's perfect. And why is it recommended to give half NS? Don't they need NS? Well, it could because the corrected sodium is higher than 140, right? And we talked about that formula on the previous slide, where it's about 2-ish points for every 100 points greater than 100. So the sugar's 800, right? That's 7 100s more than 100, so that's 7 times 2. It's 14 points of difference in sodium just based on a sugar, right? The sugar could affect it that much. All right, so make sure we got fluids running. These guys are dehydrated. They need fluids. The best fluid is LR. That's the preferred fluid. And we're checking electrolytes because we can be wasting electrolytes. Is a grossly catabolic situation where they're chewing through all kinds of ATP, all kinds of energy, and they're burning through a lot of caloric sources, so they can be losing a lot of phosphorus. So phosphorus can be extremely low in these guys. So adding those to your chemistry Q4 hours is a recommendation, right? And once they are corrected, right? So IV insulin stops, and then we have already started our basal insulin. That's our long-acting, our glargine or detamir, or those guys are going to be given, first, and then 1 hour, 2 hours later, then we stop the IV insulin, because this only lasts about 20, 30 minutes, right? Whereas this one lasts about 1 to 2 hours, or starts in 1 to 2 hours. So you don't want to have that part where they actually start going back into ketosis. Or sometimes they underdose the basal insulin, and they needed more insulin to start. Okay, and usually they're going to ask you how much sugar did they get, how much insulin did they get in the last 24 hours? And that's going to let them know how much to give, right? So it's usually about 80% of that. So if they got like 100 units in the last 24 hours, they're probably going to give about 40, half of that in right now, right? So they'll give about 40 units, and the other 40 units, right, will be given as like with meals, 20 and 20. All right, so hourly changes. So we talked about this before, but you have to have 2 sugars. If you don't have 2 sugars, meaning that your AccuCheck says the sugar is greater than 500, you have to get a lab result. So lab needs to come up, and sometimes with a sick patient, they have to come up every hour, right? And sometimes you're like behind two checks because they're slow. So you got to make sure that we are always on the phone, making sure someone else is coming up to get a sugar if our point of care sugars are more than 500. Because we need 2 sugars, we want to make sure that it's coming down nice and slow. What's the goal drop? About 50 to 100 points, right? We want a 50 to 100 point drop in our glucose. Otherwise, if it's more than 100, that's going to cause cerebral edema. So, if your sugar says greater than 500 and it's 800, right? And then it says the next hour says greater than 500, it could be 501, right? So it went down 299 points. That's dramatic, and that could cause complications. So you have lab complaints like, oh, why are you doing it again? We just drew it. It was 800. It's like, well, it could be I'm on insulin. It could have dropped dramatically, right? So we have to have that goal rate, or that goal change. And then, of course, once you put your 2 sugars in there, it's going to compare those two. If it's more than 100 drop, it's going to reduce your insulin by 50%, right? So, hey, that's way too fast. Instead of going 8 units, let's go down to 4 units, right? Or if you're going to 10 units, it goes down 50% to 5 units. If it's at 1.6 units, it goes down to 0.8 units, right? And if it's less than 50, right, it drops only by 20 points, or sugar was 800 and now it's 780. It's like, well, shoot, that's way too slow. We can crank that stuff up, right? So then it's going to go up by 50%. So it was 4 units, now it's going to go up to what? 6. Very good. So some people were like, oh, it goes 4 to 8. That's 50%, right? No, that's 200%. So this is why we have a advisor now, because we had all kinds of interesting math that happened when this was on paper, right? The hospital up the street, 10 miles up the street, they still use the paper insulin, and it's all over the place, right? It's like yeah, I'm going up by 50% from 5 to 10. So no, that's 200%. You just doubled it, right? You go to 5 to 7.5. That'd be a 50% increase. And then you had a 50% decrease for 7.5. Oh, that's like 3.25, right? So, or is that what is that going to be? So it's all over the place. So that's why having an advisor that does it for you is a much better alternative. But also we have to make sure the computer's doing it right. Same thing if you did it on paper. The other person is supposed to check your math, right? And then now you have, hopefully those 2 people can also change the light bulb, but you're going to be able to make sure that it is the correct math and it's the correct change based on what the computer is telling you, right? So you do an independent double check with every single glucose change, right? Every single insulin change. And how do you do this? All you do is you just show them. You say, just thank you. This is what I got going on. Here's my advisor. They look at it and they independently double check it. You don't tell them, hey, my advisor says go to 1.4 units an hour and I got 1.4. See right here, see right here, see right here. That is called confirmation bias, right? So you have to just make sure they are doing it independently and they then co-sign it in the computer. So HINC or HONK. unfortunately not called HINK or HONK anymore. It's called HHS or HS, right? So HS is a situation that happens with high sugar, just like DKA is, just like high sugars. So what's the difference? This is high sugars that are incredibly high, and when you have high sugars, it pulls water, makes you super dehydrated. It also makes you pee a lot, right? And if you're peeing a lot, you're going to be very, 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 very dehydrated. And so this happens with patients that are unable to access water. That's kind of the key difference between just dehydration with hyperglycemia and this kind of dehydration, which is hyperglycemia without access to water. Okay, so their inability so they're debilitated, they're acutely, mentally sick, they're sick over multiple days, right? They cannot get access to water is the key difference between this and just a hyperglycemic patient, right? So no access to water, no access to water. I thought I wrote it there. Anyways, no access to water is what's going on in HHS. Okay, so did they release insulin? Yeah, they release insulin still. Otherwise, if they didn't release insulin, what would happen? They would go into DKA, right? Because what is insulin? Insulin is the off switch for ketosis. If there is insulin present, I do not get ketones, right? But if there's insulin present, there is no ketones. So HHS used to be called HHNK, non-ketotic, which made perfect sense. Let's explain exactly what it is, right? So it's hyperglycemic, hyperosmolar, non-ketotic syndrome, right? There's no ketones because I have insulin present. Do type 1 diabetics have insulin present? No, that's why it's literally impossible for an HHS to develop in someone with type 1 diabetes. It happens only in type 2 diabetics because type 2 diabetics produce insulin. Now, do type 2 diabetics not produce insulin sometimes? Yes. Then in that case, they would go in the DKA, not HHS, right? So that's why it's rare for type 2s to get DKA. It's impossible for type 1s to get HHS. So HHS stands for hyperglycemic hyperosmolar syndrome. Why are they hyperosmolar? Hyperosmolar is just a fancy way of saying dehydrated, right? When you're dehydrated, when your serum osm is high, when your specific gravity is high, when you're hyperosmolar, that is just dehydrated, right? That is increased concentration. And what is an increased concentration? Glucose, right? And why is the glucose high? It's all the same reason for DKA, except they don't have access to water. No access to water, therefore, and they're peeing out like a racehorse because all the glucose is spilling into the urine, pulling the water with it, and they get a severe dehydration. Okay, so again, it's impossible in DM1 because DM1 doesn't have insulin. If you don't have insulin, you would have ketosis, and this is non-ketotic, right? The mortality is extremely high. It's up to 60%, right? That's more than a coin flip. So if 1, 2, 3, 4, 5, 6 of us get the HHS right now, that means 2 of us survive, right? So it's incredibly high mortality. Compared to DK, which is 5%. I mean, just 1 of us dies, or 1 of us dies partially inside, just like me. Anyway, so that's how it happens with with DKs. You have a much better recovery. 5% is still pretty high, but HHS 60% is incredibly high. Okay, glucose pulls dramatically. A lot of water, not as much as albumin, which is 70x, right? Sodium's going to pull a lot of water, but glucose is on the list, right? It's definitely going to be pulling all that water, making them severely, severely dehydrated. So what are your symptoms? Are they get the abdominal pain and the nausea, vomiting? No, because that's what the acidosis did in DKA. In DKA, we had that acidosis present. That's why it's called diabetic ketoacidosis. Are there ketones in HHS? No, it used to be called HINK, non-ketotic, the NK standing for non-ketotic, but there is no ketones. There might be ketones if they are severely, severely dehydrated and not drinking water. They're probably not eating food, right? So they might have starvation ketosis, so it kind of complicates a little bit, but it's not going to be profoundly elevated like it would with DKA. And that elevation is of ketones causes what change in my ABGs? Makes my ABGs look bad, make my ABGs develop metabolic acidosis. So they're going to have a bicarb that's low, they're going to have pH that's low in DKA, and they're going to have ketones that are present, right? Whereas HHS, their pH is normal because they don't have ketones making it acidotic. Their anion gap is what? High, low, normal? No, it would be low. That'd be called a NAGMA. That'd be a non-anion gap metabolic normal anti-GAP metabolic acidosis. So it's no change. It's 12, right? Still normal. Why did that change? Because we're not using bicarb and we're not gaining acids. Whereas the anti-GAP in DKA goes up because we have ketones, and which are acids. 2 out of 3 were acids, right? These guys have profoundly high sugars, right? Is there such thing as euglycemic HHS? No, but they have profoundly high sugars, usually greater than 600 on average, right? So when a patient comes with a sugar like 1400 and they have like a history of dementia, it's like, that makes sense. They probably have HHS because they have a history of type 2 diabetes as well. Okay, so there's extreme dehydration, extreme crenation of their cells, right? Everything shrinks. Your brain cells shrink, you get confused, right? You get SNS response because you're dehydrated. ADH is going to try to reabsorb water as much as possible, but it's doing that in the hopes that you will drink water, because it's going to, I got you, bro. I'm going to hold on to all the water, the kidneys, while you go get some water. And then they're over there with dementia, or they're with cerebral palsy, or they're over there with debilitation on the second, third floor. We're not getting proper hydration, right? So it's something to keep an eye on. And these guys are going to have extremely high sodiums, right? And these sodiums you do worry about, right? These guys are truly hypernatremic because they're not accessing water. All right, serum osmos are going to be extremely high because serum osmosis is another way of saying that is just concentration. So the concentration is high because they are dehydrated, okay? And they're not going to have acidosis because there's no ketones. Anti-GAP is normal. pH is normal. Bicarb is normal. Okay, there may be ketones, just maybe, if they're actually starving. That could cause some ketosis to develop. So the treatment, just like with our Phi-FOFUM for our DKA patients, we're going to give fluids because they are extremely dehydrated. Whereas in DKA, they were about 6 liters negative, right, when they came in. These guys, so water deficit about 4 to 6 liters. These guys are about up to 12 liters deficit, right? That's almost like burn territory when you get like the Parkland formula and such. They're getting an incredible amount of fluids. These guys are getting a lot of fluids, okay, almost double the amount. And they're definitely getting insulin because we want to get that sugar under control, right? And electrolytes, they've probably been peeing a lot, so they probably are going to need to get some replacements. So doing Q4-hour, chemistries of these patients is also appropriate. And like we mentioned, it's the same causes of DKA. It's just someone that has no access to water. That's kind of what's going on. And also they have some insulin, right, which type 2 diabetics do. That's what's causing no ketosis to develop.